The next video we're going to, and the next case we'll be looking at is socket grafting. Now, I often get asked a lot about socket grafting. How do I do this? How do I do that? How can we optimize results? Well, socket grafting is something I only do in probably 5% of the cases because I always like to place the implant. But it is an important aspect in implant dentistry and bone regeneration and true bone regeneration. So let's get straight to the point and look at it. There's two conceptual ways I like to look at socket grafting. One is immediate socket grafting, and the second is a delayed immediate process. And this fits in more with the protocol of the use of ethos that I explained in the first video. So when we look at a traditional, that's an immediate socket graft. The problem with this is you're fraught with issues of possible bone graft material loss. And this is with any graft material. Some are easier than others because we're actually, as the patient walks out the door, we've lost control of what they're going to do, how they're going to do it, what they're going to go straight to the pub, or whether they're going to sit at home like you told them, or they're going to go straight to the gym. So these factors may be an issue. The other big factor is people will never clean the site properly. So we're often then placing the graft material onto infected granulation material, and this can have a detrimental effect on the possibility of maintaining and retaining the graft. So when we look at a traditional socket graft, yes, there's a case published on PubMed that I have, and it's under my name on PubMed. So you can look at that. It's also on ethos.dental, and you can see it there. So the tooth was taken out. Now it's very important to clean the site properly. And again, degranulation burrs, the ethos degranulation burrs help us a lot. Once we've taken it out, you can see the effect of loss of buccal keratinized tissue. Now this is an important aspect, and you can see the size of the defect. What we're going to do here after cleaning it is just place the ethos, mix ethos to a medium set. Here a whole cc was mixed, and it was placed to the correct level. In other words, you place the graft material to the bone level, because this allows healing by secondary intention. In this case, we've used a simple collagen fleece over the top. Now, the reason why this was done was to concur with other studies. You can use a collagen fleece. This allows and helps us to get an initial clot over the site, or if the patient has problems with porcine products, then we can just leave it and cross suture over the top. Okay, so it's a simple, straightforward. Here we've cross sutured over. We have a lot of research showing this healing by secondary intention over stable graft materials, so we'll get slow healing over it, and eventually it will heal. So in 10 weeks, we can have, when we raise a flap, we can see we have nice now thick keratinized tissue and good host bone. All right, so when we look at it on x-ray, we'll see that the defect is, there was a root fracture here, so we needed to remove the tooth. We can see the size of the defect. We can see the infected area on the distal root. That's really important. That's cleaned out. When we graft with the ethos, you can see the graft is placed to the bone level, not above. And at about 3 to 4 weeks, this x-ray was taken. Again, it looks like we're losing the graft, but we're not. We're losing the calcium sulfate element. So don't panic, because at 10 weeks, we can see the level of the bone is back. And this is important because what we see on x-rays is mineralized tissue. We don't see what's going on in the soft tissue. We don't understand the collagen healing aspect. So it's important that when we assess our x-rays is to understand this. We then take a core sample in this site, and it's taken right from the center of this core. So right in the middle of where that big defect, that big socket was taken, this is where we're taking the bone. Why are we taking it from the middle? Well, we understand these materials have a high osteoinductive potential, and we're actually seeing the best new bone right in the center, not adjacent to the old bone, because this is not an osteoconductive process, it's an osteoinductive process, and we see this on all our numerous clinical and animal-based studies. Here we'll see actually the entire core. So look, anyone can take a core and take a little section out and show you it and say, look at the quality of the bone by just looking at one aspect. This is the entire core, and we've got over 50% new host bone at 10 weeks. This is an important aspect to look at, and this is measured by histomorphometry as well by Professor Mangum, who did the H&E stain. So when we place the implant to where we've taken the core sample from, we've already got 69 on ISQ. So we've got 69, and that's very good, high stability from right in the center of that defect. So the center of that core, where it was taken from the center of the hole, we've got 69. It then went up to 77 again after another 10 weeks. So we've got a very high stability in the implant. And the interesting thing is that in the core, when we look at little closer aspects of it, there's a very interesting slide showing a beta TCP particle entrapped fully in bone, because this is what's going to happen over time, is the residual graft material will turn over to host bone. And this is why we like it, because we're having good bone to implant contact with no residual graft material, and this allows the bone to turn over fully in the future, and it allows us to have long-term stability. This case is now 4 years loaded, 4.5 years loaded, so it's been around a long time, nearly 5 actually. So that is the traditional look at a traditional sort of immediate socket graft. As I say, what we prefer is to have a delayed immediate approach. This allows us to have a 99% success rate. Look, if you want to look at a lot more cases, visit the webinar section on ethos.dental and visit the work that Dr. Johnny Cochran does. And he does this routinely, and he has a very good technique. He does immediate socket grafting on all his cases and uses Vicryl sutures with multiple sutures over the top. So again, we've come to this situation where, yes, dentists all have varying concepts and varying ideas, and they like to use what works for them. Right, now we're going to look at the delayed immediate socket grafting approach. And this is often what I actually do just to improve, to get us to that 99% success rate, knowing we're going to get a great ridge and we're not going to lose volume and we're not going to lose material and we're going to get good high quality bone. So this entails taking the tooth out but allowing it to heal for 3 to 4 weeks depending on your skills with soft tissue. Now this idea of allowing it to heal, often dentists want to try and do too many procedures at one go. And you know, the patient's already had the trauma of actually having a tooth removed. So it's often quite a relief to the patient to go home and allow this to start a healing process. But this healing is not just the soft tissue. This healing is also about allowing for macrophage activity to remove the acute infective material deep down in the socket, which is the reason why we've had to have the tooth removed in the first place. So in this case, we're going to have that. Now we've had a 4-week healing period here, so we've got soft tissue closure. So this allows me to raise a flap. As you can see, I've started more from the lingual side, raise a flap over, and you can see early granulation tissue on the site. Then again, using curettes and degranulation burrs, I end up cleaning the site fully. Now you can see we've got a very thin buccal wall here. This is important that we graft. And here it is, grafting with Ethos. Again, I mixed a CC. I think I used about 3/4 of the CC here. Mixed it all in one go, just added it in 2 batches and stabilized it. Sterile graft, same procedure. You can see the graft material is only at the level of the bone. This is important as well. And it shows you we can now cover it with a flap. You can see on the flap that there's actually very early frail healing. So this is 3 to 4 weeks. You can see I've just used Vicryl sutures here now. I prefer using PTFE in the cases now. This is an older case, been loaded 4 years now. And you can see 4 or 5 days later, we've got nice soft tissue healing. You can see healing by secondary intention, slightly on the lingual aspect, but you can see we've got nice healing and we're losing no graft material because we have this coverage. So the graft material is not exposed to the environment where the patient's having a few beers or gone off jogging or the health club afterwards, and this could cause loss of graft material before it has time to heal by secondary intention. Again, you can see on the x-rays, yes, we've only grafted to the level of the adjacent bone, and that's an important aspect. Then 10 weeks later, you can now see healthy tissue. Yes, there has been it looks like there's been a small amount of loss, but what that is mainly because you've taken the tooth out, the effect of the emergence profile on the buccal profile of what's residual has been removed. So it looks like it's collapsed, but it hasn't actually collapsed. When we raise a flap, you can see the bone level, the new bone level. You can see against that perio probe, yes, we now have a nice new thick buccal plate. We've got nice new keratinized tissue. When we get an emergence, which I'll show you later on, this will all be restored. Again, we're taking the core sample for this right from the center because we know we're getting the best bone in there due to the osteoinductive potential of these materials, of ethos and calcium phosphate materials. Again, this is a well-known fact with over 320 high-impact papers, mainly work done by Pamela Havovich. So if you want to look into that, it's all there on PubMed. We just need to have a look around. But you can see we have a nice core sample, and this core sample was then sent to Harry Prasad, University of Minnesota, possibly the best histologist in the United States. Then we placed a Peltop implant here and placed it to the correct level and allowed it to heal for another 10 weeks. At 10 weeks time, we then took the Ostel reading. We had 75, which is adequate, which is very good, and we have restored the tooth. And we then had the results. This study is actually being written up at the moment, so hopefully it'll be in PubMed as well. But here it is 4 years later, looking at the x-ray, and we see good bone stability, further bone growth upwards, which is something that we often see. Not as extensive in this case, but we often see this case. The crown, the screw then loosened, which is a problem I had with a particular type of abutment here, and we had to then reattach the screw retained crown, and you can see, but we've got a nice emergence profile now. Yes, it's slightly, due to the loose tooth, we were getting a little bit of food, so it's slightly red there, but overall it looks very good, and you can see we've got a nice wide, nice keratinized cuff around there, and this will provide the long-term stability in this area because this is the money tooth. We know loss of attached keratinized tissue here can lead to problems with bacteria, and there it is reattached now, the crown, and you can see how we have a nice collar of keratinized tissue. Looking at the histology, this is a closer look. And the interesting thing is, yes, these graft particles are turning over to host bone. This is von Giesen staining, which is a very nice stain for looking at new host bone, and you can see the cellular activity in there, the osteoclast and the osteoclast breaking down the graft material and helping with the early remodeling. Here is a core of more of the entire core. Again, as I say, when you look at entire cores, you get the real picture of the quality of the new host regenerated bone. Anyone can take a little clip and a corner out and say this looks really amazing, but we've persistently had this over 50% new host bone at 10 weeks, and this is with using 4 or 5 different histologists, so it's been an interesting fact. And this shows the conceptual idea of this delayed immediate. All this does is it gives us a predictability that we're not subject to the environment of the host and the host activity. And this is why I like, if I am going to socket graft, I like this idea of allowing a short healing process. So thank you very much and for watching this on socket grafting.